Hi, welcome to Infusion Health, the podcast. I'm comedian Cris Patrick, a.k.a. self-proclaimed power man, and I'm here with my co-host and significant other, Rach.
Hey, guys.
Now, today we got on Professor Scott Faust, and we're talking about being your best self-advocacy, our self-advocacy being your best self-advocate in the hospital when you go see the doctor. And Dr. Faust, welcome to the show.
Well, thank you.
So,
thank you for having me.
Oh, yeah, no problem. So tell us a little bit about your background and what you do.
Sure. So I am a nurse practitioner, and I am also a professor. My clinical job is I am a hospitalist. So think along the lines of you or your loved one being admitted to the hospital.
Okay.
Years ago, your family doctor would come see you before you went into the hospital, before they went to clinic.
Uh-huh.
They might make rounds during the afternoon and then maybe the evening. And how challenging that is for a patient and the family to wait around all day for a provider to come by and see them. So about 25 years ago or so, we, as a community of healthcare providers, created the role of hospitalists or hospital medicine providers.
Okay.
And it's either a nurse practitioner, a physician assistant, or a physician.
Mm.
We all have a very similar boots on the ground job or role to fulfill, and that is to be the quarterback, or as I affectionately say, the air traffic controller of managing your care.
Mm-hmm.
And so we're the ones who see you daily or your loved one daily or multiple times a day to come in. And we're kind of the primary or the family physician or the family provider, your primary care provider while you're in the hospital. So, and then in addition, I teach nurses and physician assistants and medical students who have an interest in hospital medicine or critical care, which is a subspecialty of hospital-based medicine.
Okay.
And teach them how to be not only a skilled clinician, but the importance of helping patients and their families advocate for themselves.
So if somebody goes into the hospital, they see you first, or?
Well, so it depends on how they come into the hospital.
Okay.
If you come in from your clinic, so you go to see your provider in the clinic, and they say, hey, you've got something going on. Heart, I'm concerned of a heart attack, or I'm concerned of, you have an infection, that it's best treated going to the hospital versus being treated as an outpatient, then you can come in through what we affectionately say the back door. And that is, they call the office, they call the hospital. We arrange to do a direct admission to the hospital.
Mm-hmm.
That's probably about 20% of the time. The 80% of the time is you come in through the emergency department. So you come into the ER and you're seen by a provider, whether it's a nurse practitioner or a physician or a PA.
Mm-hmm.
And during the process of working up, you're deemed that you need to be admitted to the hospital.
Okay.
They then contact us or one of my colleagues, myself, and they talk about your case. And they say, why do you think you need to be admitted to the hospital? What's going on? What we do know at that moment in time, and knowing that can change from time to time and minute to minute. And more importantly, what else needs to be done that is urgent. And then once that decision to be admitted to the hospital is made, someone like myself will come down to the emergency department or wait till you get upstairs to your room. And then we come in. And oftentimes it's a trying time for individuals. And oftentimes people are going, don't you people talk? Don't you know why I'm here? But oftentimes we're asking them the same questions. Mm-hmm. And it's not because we don't talk, but as I often tell folks, while we may be the experts of healthcare, you're the expert of you.
Mm-hmm.
And together we can figure out what's going on.
Right.
And so what we're talking about today, being your self-advocacy, what exactly is that?
So that is, in essence, putting yourself out there and advocating communicating, for lack of better words, your needs as a patient
Mm-hmm.
or as a loved one of a patient.
Mm-hmm.
And there's a right way to do it and a wrong way to do it. So, I mean, and that's what my whole show was based on, how to be your best self advocate. So, the negative way to do it would be being very hostile, having, and it's understandable that you're hostile. You don't know what's going on. You're confused. You've been waiting forever. You just want the answers. But there's a way.
Absolutely.
Yeah. And there's a right way to do it and a wrong way to do it. And it's not coming out of your room, start yelling at everybody. It's being patient. And when somebody comes into your room, saying, how much longer is this going to be? And unfortunately, we don't always have the answers because especially in the ER, there might be tons of ambulance just came in and they take priority over you. And I'm sorry for that, but you have to understand where your place is. If you're having a heart attack, if you're having something emergency going on, then you're going to take priority over somebody that's just broken their arm.
Very much so.
Mm-hmm. So go ahead.
No, you go ahead.
So being your best advocate, you're saying that you have to wait and like Rach was saying, this person has a more severe thing than you, then you got to wait and stuff like that, and people get impatient, people and communicating exactly what's wrong with you, not leaving anything out. Is that what you're saying?
Very, very much so. And I think, I jokingly say, but there's some truth to it.
Uh-huh.
When you meet me or one of my colleagues, when you woke up this morning, unfortunately, you weren't planning on meeting myself or one of my colleagues.
Uh-huh.
People don't come to see us necessarily because they want to.
Mm-hmm.
Uh-huh.
Instead, they're coming to see us because they have to.
Right.
Uh-huh.
And there is a concept, and I know it's been talked about on kind of both your podcast in the past and other podcasts, the idea of triage, or how do you get to being seen in the hospital?
Mm-hmm.
Mm-hmm.
And triage is a French term to basically, in the simplest terms, means sort it out.
Right.
Mm-hmm.
And as Rachel was saying, when we see people, there's a limited number of us, and there's many patients. That's just the fact of the matter.
Uh-huh.
But we have to be able to see everybody. And so we do a triage system. And basically what that means in very simple terms is we take the life-threatening or the potentially life-threatening first. And then we go to the people who are most seriously ill but stable. So it could be someone actively having a heart attack is going to be seen before someone with a broken arm.
Right.
Someone who has a bad pneumonia and is having a hard time breathing is going to be seen before the kiddo who's got flu. And our hearts go out to those who are having to wait, and we empathize with those having to wait. But in order to take care with limited resources, meaning limited people, limited anything, we have to take care of the most serious first.
Is it fair to say, sorry, is it fair to say that somebody bleeding would beat somebody over a heart attack, would be beating somebody over a heart attack, are symptoms to a heart attack?
Quite possibly. It all depends. It's a case-by-case basis. Case-by-case being, not to get too technical, but we're going to, in the whole scheme of things, take care of people who are having a hard time breathing first, because if you're not breathing, you're not perfusing or moving that blood around.
Yeah.
If so, we have an acronym that we use in healthcare, and it's very simple, but it's very important. It's A, B, C, and D. So airway first. So are you able to breathe by yourself or do you need assistance? Breathing, are you breathing?
Mm-hmm.
C, is that circulation, so the bleeding. Do you have a pulse everywhere you're supposed to have a pulse? And then D is disability. So are you altered? Are you alert and oriented? And are you acting appropriate? Or do you have something going on that is more concerning, like a stroke? There are also certain issues that are very time sensitive. So in order to treat somebody with a stroke or a heart attack, we have a finite amount of time in order to act.
Yep.
Uh-huh.
And we jokingly say, and there's some truth to it, patients, when they come to the hospital, they haven't read the instruction manual, meaning not every diagnosis that we read about in a textbook presents the same way 100% of the time.
Uh-huh.
Yeah.
Everyone comes to the emergency department or the hospital with a full stomach, meaning there's more issues to deal with and you just ate, and there's potential complications. And I think one of the biggest concerns, and what personally as well as professionally, is that as healthcare providers, we think that we communicate, but research has shown that we really don't communicate as well.
Yeah.
Mm-hmm. Yeah, because I remember when you talk about, a broken arm, somebody not breathing has a priority over somebody with a broken arm. I remember watching the show MASH with my dad, because my dad was in the Korean War, and he's like, yeah, he goes, what they do is they look at a patient and like, okay, this person needs to get in the operating room right away. This person can wait. This person ain't gonna, it's not, no matter what, and he ain't gonna survive no matter what. So, and they got to make those quick decisions like that, but that's during wartime. But also too, to the listeners out there, if you go into the hospital and you're wondering why you're waiting so long, or you got to go into the ER, I think it's safe to say that depending on what's wrong with you, you might have to wait, because in the hospitals they are going through limited staffing and limited, and not only that, but the people who are on staff who have been working, 24, 48 hours and all that, everybody's getting burnt out. So you just got to wait and be patient.
Absolutely. I think another fault that we have is when that patient's in that room and we have these cell phones in front of us now that can give us false information if we're not looking at the correct source. So that even heightens our fear, So we get a little bit more testy because we don't have the person in there. So we're scared about what's going on because of what we just read.
Absolutely. And new within the past year or so, there is new rules and mandates that as healthcare providers and as patients and consumers, and keep in mind, as healthcare providers, we're also human. And just like everyone else, we've been to the doctor, we've been to the emergency room, and so we get it. And because of that, collectively, there's now things in place that require us to disseminate or disclose or provide information to patients in real time. Mm-hmm. So as Rach was saying, you could be in the ER. You may have seen a provider. We may have already started working up whatever you come into the emergency department with. And if you have a smartphone or your tablet or your computer and you're logged in and you have access to your electronic medical record, unlike years before, and I'm talking very recently, you can actually get your medical records and your medical results, your tests, your labs, your imaging results quicker, and you may very well see your results before I or one of my colleagues sees them. Right. And so you may have that information when I come in to round on you. Mm-hmm. Mm-hmm. And the other thing is, and we'll kind of, if you want to talk about it a little bit later, we certainly can, especially in how you advocate for yourself, but you also have access through the electronic medical record of seeing your notes and seeing your medical records in real time.
Right.
So being your best advocate doing self advocacy and doing self advocate on yourself. I mean, you have this stuff coming to you that you can get on your cell phone. I'm not sure what the app is, but a lot of places have an app that you can join, and that can get your medical records, and that can get your stuff. So when you do go into the ER, you can say, hey, this is what's going on here. This is what I got, which also helps with the process. Which helps with the process a lot better. But I'm not I'm not in the medical industry. Rach is, and dealing with people who have been in rooms who I want to get something to eat. You haven't changed me. You haven't, I'll let her talk more about that.
So yeah, what you're referring to is what a lot of CNAs and nurse carers do, and we are trying to get you your food as soon as possible. We understand you haven't eaten in 24 hours, and we want to get you that food. But if you're having a gut problem, maybe it's not the right time to be able to get something to eat. We might be able to get you ice chips, but there's tests involved that you absolutely cannot eat, drink, do things at that time.
Very much so. And we know that when you're hungry and you're tired and you're scared and you're in pain, I'll be honest with you, the ability to be nice or the willingness to be nice sometimes goes out the window.
Absolutely.
It's a human reaction.
Yeah.
And that's the thing too, is that you've been in there. You've been in there for I don't know what the wait. What's the average wait time now for?
It depends on what's going on. So if the pandemic spike is a little higher, then it's absolutely going to take even longer to get out of the waiting room in the ER to be seen in triage the ER.
So what are we talking? An hour, 2 hours, 3 hours?
If it's a good day.
3 hours.
If it's a good day.
Yeah, if it's a good day. I know people that have been down in the ER for 36 hours before they come up to us.
Oh, okay. And and yeah, 30. Well, I know 36 hours. That's like a few days, 3 or 4 days.
Yeah.
Are no, a day and a half. A day and a half of sitting down there. I haven't been seen. I would get a little cranky too. Like, hey, what's going on?
Oh, absolutely. And especially if you're scared or you're seeing a different provider every day.
Mm-hmm.
It really, and one of the things to keep in mind is, as a healthcare provider, regardless of our role, we have one chance to get it right.
Yep.
We have one chance to establish that trust. And you're right, Chris. If you're sitting in the ER 36, 48, 72 hours waiting for a bed, it's frustrating, because personally, having been a patient, I tell you, those ER stretchers, they're comfortable for about the first 30 minutes.
Yeah. Absolutely. And just to touch base, something that I had personally talked to you about in text, these smaller hospitals rely on the doctors that you would see out in the community, for myself, I dealt with a doctor that was in control of taking my grandparents' life. And what I mean by that is my grandpa was having heart symptoms. 5 years before, had a triple bypass. He had went to the doctor that he had always trusted and said, I'm about to jump on a plane to Texas. Should I go, or should we look at my heart? And he did a simple EKG. It wasn't terrible. He said, we'll deal with this when you get back. And my grandpa didn't come back alive. And my grandmother was very old school. And back then you did not change your doctor. You did not change your physician. You did not do these things. And she had not. And at the age of 78, we had lost her because he had never done a colonoscopy on her. Going forward in my time, there was times in urgent care and in the ER that I would see this doctor. And for our smaller hospitals, you don't have choice over that sometimes. You can't get another doctor in there. And I understand that you're scared and frustrated and why do I have to have the same doctor? But I have 5 kids. And when they would get sick with strep and he would be in there, it wasn't a choice that I had, right? So you had to use your own personal patience even beyond, even beyond, because you're grasping at, why do I trust this doctor? But the thing is that you have to understand the hospital trusts them to a level to be able to get a simple diagnosis right for you.
I think, first of all, I'm sorry you had to deal with that. No one should have to deal with that. And I think as much as we know about healthcare, we also, unless you're in the industry and you're walking through it, you may not know the nuances. And so you're very much correct that there is a supply and demand issue, especially when there is a great demand. But we know that for many reasons, the numbers of people graduating from medical school and residency are down. People going into primary care as a specialty are less. People are wanting to go more into subspecialization. And so cardiology, dermatology, pulmonology, which deals with the lungs, infectious disease. And so the number of providers consequently is decreased. Mm-hmm. Then you're dealing with a small community that may have one hospital or one medical center for multiple smaller communities in the area. And it really comes down to working with what you have. That is even before we talk about other disparities in healthcare. The numbers and the statistics that I have are shocking and mind-blowing. Mm-hmm. But the good news is there are ways to help mitigate that. And hence why I believe we all need our advocate. And in fact, I was talking to my dad yesterday. My dad is elderly. He lives independently in his own home. My sister lives with him as well, and she helps to advocate for him. Mm-hmm. But what you really said struck me to the core, and my dad and I have had conversations with this. The whole concept of advocacy is much newer. Yeah. And so many people may not realize that they not only have a choice in advocating for themselves, they really have an obligation. Because if you look back, up until recently, healthcare itself has been very patriarchal. You went to your physician, you went to your provider, whether it was a nurse practitioner or a physician assistant or a physician, and you collectively went to a provider. And you talked to the provider about your symptoms. And as the provider, we had a finite amount of time to do an exam, get history, come up with a working or a concrete diagnosis, and implement a plan of care. And so it used to be you come to the doctor, you tell them what's going on, an exam is done, history is taken, we look at labs, you come up with a diagnosis, and we give you a prescription, a treatment plan, and you go out.
Right.
And it was, thank you, doctor, yes, doctor, and you go about your life. Yep. No one really, until recently, has really started questioning. And since about 1985 to 1990 onwards, we've really started getting much more involved. And we've gone from a paternalistic or patriarchal hierarchy of medical care to one that is very important, and that's called shared decision-making. And that's where you become the active participant, because once again, while I may know a lot about hospital medicine and acute and chronic illnesses, you and your family member are the experts on you and your family.
Yeah.
So asking you and Rach, I mean, what do you do as far as somebody coming in and they're just like, they haven't been seen, they're sitting there waiting, and they're like, I want this drug, can you can you administer that drug or?
I personally cannot administer the drug. It's usually the nurse that gets the script from the physician to the pharmacy, and it finally comes. That's another problem that we have. Sometimes the pharmacy is working on so many patients that we can't get the medication to them at the proper time.
Well, I'm talking like somebody who's like, I need Vicodin. Give me Vicodin right now. I want Vicodin.
Before we even address those, we try to find other alternatives.
Okay.
Very much so. And, it brings up a higher philosophical question. Just because we can doesn't mean we should.
Yeah.
Is the Vicodin, for example, the right prescription for you? Is that the right treatment? What I really strongly believe in my team and myself, as well as others, the majority of us within the healthcare community, we want to help you. And I think the best way we do that is instead of just giving something willy-nilly and just write up for something, instead is to get deeper to the problem at hand. Mm-hmm. And the way we do that is through communication. Yeah. And is that always easy? No. If you're in pain, if you're hungry, if you're tired, you're not going to advocate for yourself. Mm-hmm. And unfortunately, there are, biases out there. In fact, I read there's a recent study that shows that 1 in 5 cancer patients report unfair treatment because of either their finances, their disease status, or race. Mm-hmm. And trust is key. What we know through studies and research is that people and individuals, they can discern when their healthcare provider truly cares about them. Mm. And to be honest with you, that makes all the difference in the world.
Right.
So what do you think as far as, you get somebody who lives in a nice community, has insurance, has that, or somebody who lives in a lower lower urban community or something like that, doesn't have the insurance, works 2 jobs and all that just to pay the bills and all that, but can't afford good medical treatment. Do you think there should be something all the way across the board where everybody should be able to get the same medical treatment?
I think what you're talking about, and we can talk to Professor Scott about this in a future episode, is you're looking at 2 patients come into the ER. One is a cop, one is a criminal. Who do you take care of first? And you have to take yourself out of how much their money they're making, who they are, and all that, and actually look at the body and say, can I heal this body in this moment? And which one is more important? Which one's more dire in that moment?
Yeah.
Absolutely. So when you come to the hospital, the idea is, regardless of who you are, what your background is, what's going on, all of that goes out the side. Uh-huh. What we're seeing in a triage situation is 2 individuals who need help.
Yeah.
Now, there is at least the perception, if not, objective evidence to support, there is certainly the perception, and most likely, I'll be honest with you, I'm not as familiar with the literature, mm-hmm. but I can tell you that there's likely literature to back it up, that there is a discrepancy, and that the ideology of, or the idea of, equal access and equal care, it doesn't happen.
Right.
As you were saying, Cris, look at the inner city hospitals, look at the urban environment, look versus suburbia, or, the haves and the have-nots. Uh-huh. But regardless of who the individual is or their ability to pay, as humans, we all have the obligation and we have the responsibility to treat each other with dignity and respect. In the same study that I was talking about earlier, 25% of patients said their provider never asked themselves about what mattered to the patient. Mm-hmm. We talk about time being of the essence, and whether you're being seen in the clinic or you're being seen in the hospital, A recent same study showed that 11% of patients said the last time they visited their provider, they didn't even have the time to discuss the most pressing healthcare concerns.
Uh-huh. So how do we
sorry,
fix
Chris,
that?
I'm going to stop you for a second. I think the best, and to answer your question, I think the best way to answer that is for physicians to have that personal communication with them. What are you doing in your life? I think that also lowers the patient amnesia. And what I mean by patient amnesia is there's so little doctors and so many patients that if you have a personal connection, just like a stranger on the street, you're not going to know somebody that is driving next to you. But if they roll down their window and say hi, you're going to remember that for days.
Yeah. Yeah.
So I think it's important for the patient to have that personal conversation with their physician, with their nurse, with their aide. And it lowers down even the fear in the patient, and it hires what we're doing in the hospital because we have now a personal connection with this person.
Mm-hmm. Mm-hmm.
Absolutely. And I think, and I know from a quarter of a century of being in healthcare and doing this through a variety of roles through the years, the most important is for the person, the patient, the individual to tell the team, the doctor, the nurses, the aides, the therapists about them as a person, sharing a few details about things that are most important to you. Are you a parent? What do you do in your free time that brings you joy? What is your day-to-day activities? She talked about this earlier, the person who is financially affluent versus someone working two jobs.
Mm-hmm.
Does it come down to, and a lot of people are ashamed or embarrassed, and you shouldn't be, but they're often embarrassed that they may not feel comfortable speaking up. And as a provider, I write a prescription for the latest and greatest drug. There's so many insurance plans out there. There's so much healthcare coverage out there and different funding sources. I don't know what everybody's insurance plan covers.
Uh-huh.
And it may come down to you having decided, do you do drug X that's $4,000?
Yeah.
Or do you eat that much?
Yeah.
So talking to us about you as a person, because once again, it goes back to the whole thought of we may know medicine, but you know you.
Right.
Yeah.
And especially our parents and our grandparents, and those of us who are fortunate to have great grandparents, they are probably more along lines of it being a hierarchical or patriarchal medical system.
Yep.
Mm-hmm.
And I'll be honest with you, they either don't know or they don't feel comfortable advocating for themselves.
Right.
Yeah.
And I wish to tell you that the days of where you had your physician or your provider who followed the family for years, the cradle to grave, that's really long. I mean, that's long gone.
Mm-hmm.
It is not uncommon for someone to change providers. And we expect that, or there's this understanding that, well, it's in my medical record.
Mm-hmm.
And unfortunately, oftentimes, especially as we age and other healthcare issues take priority, our medical record becomes very voluminous. It becomes very large.
Mm-hmm.
And we end up, it may be in the medical record, but it may be buried so far down.
Yeah.
So
and
I
just
tell
to
people,
Scott, to touch base on that, sometimes we don't have access to those records yet because they're in a different hospital, different clinic than what we have access to in that moment.
Absolutely. One of my dreams as a healthcare provider is that we would have a universal healthcare record. I don't think that we will get there in my lifetime or your lifetime, but I'm hoping that for our kids and our kids' kids in the future, that we will somehow have a universal healthcare, because you may come to hospital A, but your primary care doctor is affiliated with health group B,
Mm-hmm.
And we may or may not have access through the back door to getting your records. So one of the things I tell people, and it's very apropos, is write down not only the salient or the most pressing issues that you've had, both historically and currently.
Mm-hmm.
And so if you've had a heart attack, if you've had pneumonia, if you've been hospitalized for something, what surgeries have you had?
Mm-hmm.
Write it down. Either write it down if you are old school and you're a pad and a paper and pencil.
Mm-hmm.
Write it down and update it as things occur. Or if you feel more comfortable with technology, using a smartphone app or even just opening a page on one of the apps on the phone
Mm-hmm.
and making a list, that will go much further for you, because when you're stressed and you're sick, you can just look to it.
I think one more note before we close. Also have the communication with your family. You might be in an accident and then you've never told anybody in your family what your wishes are. So I think even at a young age that we should start having more of those communications so that your children even know, hey, mom's more into health, holistic before she goes into the ER, right? Or mom has had this surgery or that surgery. I think we're also stuck in that old school where we don't tell people what's actually wrong with us.
Absolutely. There's an acronym out there that I think is really important us to look at, and that acronym is HEAL, and we can kind of go into it. But HEAL, the H stands for honor you and your provider's time. I think a lot of times people are like, well, they're the doctor. We have to be, mindful of their time. Your time as a person and as a family is just as invaluable.
Mm-hmm.
To your first point, or your second point, was also the E in the acronym HEAL is be an expert. So the E in expert, be an expert in your body. So know your body. What surgeries have you had? What medications have you tried?
Mm-hmm.
The A is to assemble your own healthcare team. And the healthcare team, in addition to the providers, is your family or your friends or your loved ones. And communicate your wishes, what you would want. And the nice thing is your wishes, because you're human, are going to change as we just naturally evolve and we age. But communicate and keep your friends and your family updated on your wishes.
Mm-hmm.
And then most important is L, and that's listen not only to you, your provider, but more importantly, listen to yourself. Listen to what's going on. Advocate for yourself. Most importantly, through all of this, is make sure you, as the person who's getting healthcare, gets your questions answered.
Yeah.
Rach has heard me say this time and time again, and it's very important and it's very true. And I hope if listeners don't take anything else away from this, is that we are truly your partners. We're here to walk with you and help you through this, but we can only help you if you help yourself. So ask questions. And if you've asked the question 100 times, but you don't have the answer, or you're still confused, ask it 101.
Yeah.
It's your job to ask the question.
Yeah.
It's our job as a healthcare team to get you the information, and more importantly, get you the information in a way that you understand it.
Mm-hmm. Well, Professor Scott, this has been an interesting conversation. If people want to get a hold of you, do you got a website or email or?
I do. It's ST Faust, so S as in Scott, T as in Tyler, Faust, FAUST at me.com. I also advise and recommend folks, kind of as LeVar Burton used to say on Reading Rainbow as a kid, don't take my word for it. Go out to the National Patient Advocate Foundation, and that address is www.n as in Nancy, A as in Apple, P as in Paul, F as in Frank.org. There are a variety of toolkits and information about how you can be an advocate for yourself or to others. And most importantly, reach out, ask questions. And we work to be patient and realize that we're in this together.
Absolutely. And all of that will be in the show notes.
Yeah, all that will be in the show notes. Rach will have that all in the show notes. Well, thanks a lot for joining us, and it was an interesting conversation. I think we'll definitely have you back.
Absolutely.
And I'll let Rach close us out.
All right, you guys, if you loved this, please tell us that you loved us. If you want more like this or have other topics of conversation that you want us to have, please reach out and let us know. That will also be in the show notes. Dr. Frost, Professor Frost, thank you for joining us. History is born on lines of hate, but on here we're trying to build lines of love and make you guys your best advocate. Have a great one.
Take it easy.